Welcome and good afternoon. It's great that you are here on the last day of PCR London Valves to this case in point session sponsored by Abbott. It's on best contemporary clinical practice for TAVI. My name is Mohamed Abdelwahab from Leipzig. My co-moderator here is Maurizio Taramasso, who is a cardiac surgeon from Zurich, and we have a very expert panel. And the session, it's a case in point session, so it's based on a case. And the objectives of the session that we are trying to highlight within a real heart team discussion is to learn a little bit about new trends for TAVI in younger patients, to understand the concerns we may have when we are deciding for a specific device in patients who have a longer life expectancy, and to try and appreciate how valve design and implantation technique may impact all of these long-term outcomes that we have to consider when treating patients with a long life expectancy. That being said, I think we will start right away. Maybe Maurizio, you just remind the participants
before
to
just
interact.
Moving to the case, thanks, Mohamed. I would like to remember you and also encourage you to put your question on the chat. We have a chat master, Caterina Gandolfo, will try to address your question or maybe bring it to the panel for discussion. So please, let's try to keep the session interactive.
Yeah, so go to the microphones, use the app. You're all experts now with the interaction. So Henrik Dreger will be presenting the case, and then we'll stop afterwards. We'll discuss briefly a couple of points and then get back to Henrik.
Well, thank you very much for the introduction, and it's my pleasure to present today's case. So here are my conflicts. So it's a pretty standard case. It's a 72-year-old female. She is a newer class 2 due to severe aortic stenosis with a mean gradient of 45 millimeters of mercury with an area of 0.8. She has preserved left ventricular ejection fraction and just arterial hypertension. She's somewhat obese with a BMI of 34 kilograms per square meter. And the main problem in her case basically was that she flat out rejected surgery because she had some bad experiences in her family with cardiac surgery. So we had to discuss the options, of course, with her and how we alternatively treat her. So this is just an additional echo. You see the mean gradient of 45 millimeters of mercury, and you can also appreciate her preserved ejection fraction and some left ventricular hypertrophy. Her EKG was basically unremarkable with sinus rhythm and no conduction delays, and this is the planning CT. So as you can appreciate here, the area was about 340 square millimeters with an annulus diameter of 21 millimeters perimeter derived. So fairly small annulus, especially for a patient that is obese. The calcifications were rather low. This is the annulus regarding the uptakes of the left and right coronary. And as you see, the right coronary was no issue at all with almost 20 millimeters distance between the annulus and the ostium of the right coronary. But the LCA uptake was rather low with only 8.1 millimeters between the annulus and the ostium. So, of course, we did a VTC assessment and simulated a 25 millimeter valve. And as you can see, the RCA, I mean, no problem at all because the distance between the annulus and the ostium was already quite large. And now we have 4 millimeters of distance. And for the left coronary, it was 4.5, so also sufficient in our estimate. And also regarding the STJ, there was 3 millimeters throughout of distance between the sinoterminal junction and the potential stent frame. So this is the axis, as you can see, no problem at all. Fairly patent arteries with no severe kinking on the right side. So as we always do, we did a coronary angiogram before the procedure, and the right one was unremarkable, but the left coronary revealed an angiographically intermediate stenosis of the mid-LAD, and so we did an RFR pullback, and it was significant, so we put in a stent, fairly simple procedure with a good outcome. But now her, of course, comorbidities were also coronary artery disease, so this is something that we also have to keep in mind when deciding which device to use for this rather young patient. So To sum up, these are the key points in my perspective for the device selection. She was a fairly young patient, female, so she has a life expectancy of probably at least 15 years. She has coronary artery disease, she has a lower LCA uptake, and she has a smaller annulus with, of course, a risk for patient prosthesis mismatch. So those are the concerns we had when selecting a device. So the question is, how would you treat this patient? Maybe the panel, maybe you in the audience.
Yeah, thank you, Hendrik. So may I ask you to take this with you for the
sure.
discussant? So I think this case has a lot of points that are worth discussing. So don't be fooled that this case appears to be anatomically simple. So it starts, of course, by the fact that this is a patient that can be treated surgically. She's 72. She has a long life expectancy and she has a low takeoff of the left coronary artery. She has some coronary artery disease, but apparently this is not in the room anymore because the patient refused. So we now need to figure out how to optimally treat these patients with the transcatheter valve. And as mentioned, there are a few problems. There's the small annulus. We have the low takeoff of the left main. It appears that at least the risk of acute coronary obstruction is not high according to the measurements, but then we have coronary access, we have pacemaker issues that are often common also in patients with a small anatomy. So a lot of considerations. So we will start maybe tackling the first point, which is the small anatomy. Philippe,
yes.
Very high probability of patient prosthesis mismatch.
Right. This is typically the type of patients who was at risk for severe mismatch. So small annulus, large body size, female patients. That's typically the risk factors of mismatch. Furthermore, once you have mismatch, the impact of mismatch on outcomes will be more important in the younger patient than in the elderly patient. So typically, this is the patient that are at risk of mismatch. So I think what is important to consider now is how we're going to define mismatch, okay? And typically, we're going to use the effective orifice area of the prosthesis index for body size. And if it's lower than 0.85, this is moderate mismatch, and lower than 0.65, this is severe mismatch. But in obese patients, such as the patient we have here, because I think that the body mass index is at 34, you would have to use lower threshold as recommended in VAC3 because in obese patients, of course, you have an over-indexation. So you need to use lower threshold. So it would be 0.70 for moderate mismatch and 0.55 for severe mismatch. The other thing you have to keep in mind is there are two different methods in the literature that we'll see. There is the measured method and the predicted method. So, and it varies depending on the source of airway. If you measure the airway directly in the patient by Doppler echo, this is the measured method, and you index for body size, and then you apply the threshold that we just saw. The limitation of this method, it is, of course, influenced by the hemodynamics of the patient. So, if, for example, if the patient is in low flow state, such as it might be the case in these patients, well, you may overestimate the mismatch. You may have a pseudo-severe mismatch. So the other method is a predicted method. Here, no measurements, no Doppler echo. You take the normal reference value of the model and size of valve. Of course, you need to have these tables with the normal reference values. They are available for surgical valves, less available for TAVI valves, but we do have these tables that comes from, collabs. And for example, if you have a Sapien 323 on the slides, the normal airway is 1.45, and you divide by the BSA of the patient, and you got your answer. And this is important because most of the surgical series, they use the predicted method. Most of the TAVR series, they use the measured method. And so you have a difference because typically you will see less mismatch with the predicted method and more true severe mismatch with the predicted versus the measured method.
Do we have any comparison between the impact of both methods on outcomes?
Yes, we do. In TAVR, actually, you see that often the predicted method has strongest association with outcomes, probably because it is more specific to mismatch, whereas the measured method is a composite of several things, And same in TAVR, what we found is there's less mismatch with the predicted versus measured, but when there is mismatch with the predicted method, it's more strongly associated with outcomes in both SAVR and TAVR.
Okay. Okay, so tell us maybe a little bit more on the impact of PPM with surgical valve replacement and with transcatheter valve replacement, because this is also a bit of a controversial issue, correct?
Yeah, exactly. So typically, if you look at the trials that compare TAVR versus SAVR, in terms of incidence of mismatch, first, you see that in general, especially with the self-expanding valve, you have less mismatch with TAVR than with SAVR. And interestingly, even in the small annulus, the TAVR appears to be very forgiving. You don't see any increase in mismatch in the smaller annulus, whereas with surgical valves, as we very well know, the incidence of severe mismatch will increase dramatically and exponentially when you got into the small annulus size. So it's really in the small annulus that it makes a lot of difference, a TAVR versus a SAVR, such as the patient that we're discussing today. And now you may say, well, is there any difference between the different platform of TAVRs? Yes, in general, you will see less severe mismatch with the self-expanding versus the balloon expandable. Initially, we thought that maybe the self-expanding supraannular versus intraannular will make a difference, but more and more data we have actually seems to be more a feature of the self-expanding than intraannular versus supraannular in terms of incidence of mismatch. In counterpart, I have to say, because when we think about hemodynamics, we should think about forward, but also retrograde hemodynamics. In general, self-expanding have somewhat more paravalvular regurgitation in counterpart. And in terms of impact on outcomes, in the SAVR series, of course, we have much more data, and we have now meta-analysis and showing clearly that the severe mismatch, essentially, again, in vast majority of the case, assessed by the predicted method, is associated with an increased risk in mortality and heart failure hospitalization. In the TAVR series, the data are more conflicting. Some studies showed association, others modest association, others no association. And I think this is mainly related by the fact that most of the study used the measured method that overestimates the mismatch and the severity of mismatch. And also, we have less patients than in the SAVR series, and also shorter follow-up. And the impact of mismatch may be more in the longer term than the short term. So I think we still have to wait. And one of the, maybe the most concern that we have is more about the durability of the valve. If you look at the surgical literature, severe mismatch is very often associated with higher incidence of structural valve deterioration, and so less durability of the valve. And this may explain why you may have more and more impact when you go into longer follow-up. And typically what you see coming as risk factor of SVD, severe PPM, high residual gradient, female sex, that is a small annulus size, all indirect marker of severe mismatch, right? And when so we don't have this data up to now for TAVR because we need longer follow-up. However, yesterday, Dr. Mollman presented data from the Portico series, large Portico series, and this is, to me, one of the first study where I've seen a strong association. So severe mismatch was relatively rare in this series because it's self-expanding, and but when it occurs, it was associated with a markedly increased risk in bioprosthetic valve failure. So meaning that you may have an impact in TAVR as well. And when you come to think of it, there is an advantage, logical advantage, to have a larger airway to start with, because you're going to have more airway reserve. And if you lose some of the airway because of structural valve deterioration, subclinical thrombosis, whatever, if you have a large airway reserve to start with, you can afford it. But if you have severe mismatch, small airway reserve, if you only lose 30% of your airway because of structural valve deterioration, you're going to be back to severe stenosis, and you may need a reintervention.
Yeah, it's a good point. I mean, you're starting like you have worse cards from the beginning because you're starting with a small area and already high gradient, so you don't have a lot of backup. Yeah.
And also, it will impact the lifetime management because you may need a reintervention sooner. And if you do a TAV in TAV, if you start with already a severe mismatch, of course, the TAV in TAV may not improve this severe mismatch, and you're gonna, still have this issue. And one thing that have been shown, at least for valve in phase surgical bioprosthetic valve, if you have a pre-existing severe mismatch, this is associated with worse outcomes following the valve in valve.
Yes, so now we understand the definition of PPM. We understand that it's probably more common with surgery, unless in these small anatomies you do some ancillary techniques with root enlargement and so on, we understand it's bad for outcome, and it's also probably bad for valve function and durability. Let me get back to the measured versus predicted, because I think this is something that, at least for myself, I wasn't aware of until very recently. So measured versus predicted, should we do like a prediction in a case such that has been presented now by Hendrik to try and understand if this patient is going to get a PPM, and could this more or less impact our decision-making process on valve type and size selection? Do you think we should be doing this?
Yeah, I think so. That's the surgeons often do now. You know, if they plan to implant this model and this size of valve, they have this chart where they have normal reference value. Of course, the challenge is to get reliable sources for your reference value, and you do the simple calculation. It only takes a few seconds, and if you're above 0.85, you say, okay, I'm good. If you're really in the severe range, this is where it's clinically significant. Well, this is where the surgeon may think, okay, maybe I should choose another type of valve with better AOA ability, if you will, or do a root enlargement in this patient because I want to avoid the severe mismatch. And I think we could do the same planification and prediction in TAVR. This is very easy. Of course, we'll need all the reference values for all the model and size. What we have now is more for the Evolute, the SAPIEN 3. We have this from the core labs, but we will need to establish that for the other valves. And then you know the sizing in advance with the CT. You know which valve you're going to use a priori, and then you can predict the normal reference value. Of course, there may be some variability depending on the degree of expansion, etc., and oversizing. But it at least gives you a ballpark of what you expect to see in this patient. So we could do that in this patient, for example. You could predict, a priori, if I implant this size and this valve, I'm going to get an AOA, a normal AOA of that, and this is sufficient or not for this patient.
And if we want to compare different valves, different THVs when it comes to PPM, I mean, our thoughts were a bit simplistic in the past. We thought, okay, infraannular versus supraannular. Supraannular is better. Self-expanding versus balloon expandable. Self-expanding is better. But for example, how does Navitor or come into this equation? It's a bit infraannular, but it's a self-expanding valve, and it seems to have very good hemodynamics and a rather low rates of PPM. But how can we explain this mechanistically?
No, I think it's more the shape of the stent. And the design that is different. Actually, we thought that maybe initially it was more the intraannular versus supraannular that was the most important in terms of AOA's gradient and mismatch, but realized with more data that it seems to be more self-expanding versus balloon expandable. Now, is the difference between the type of valves in terms of gradients, AOAs, and mismatch sufficient to in the long term, determine a difference in outcome? I don't know. We don't know yet. We need to maybe have randomized trial, etc.
Okay.
But I think it seems to be an advantage of self-expanding in general versus balloon expandable in terms of mismatch.
Okay. Maurizio, any burning questions from the participants on the topic of PPM?
No, I think we explore. There is no doubt that severe patient prosthesis mismatch has an impact. I think we should do everything that we can do to try to avoid it, not only in young patients like the one that we have been discussing, but I would say always. And it's not that uncommon that we have patients like this, especially female with big BMI and small anatomy. In surgery, to perform a root enlargement in this context would increase the complexity of the operation, the risk of bleeding, and we have to acknowledge that many surgeons, they implant a rather smaller valve because it's technically easier just to put a smaller valve. The patient goes out from the OR, but then you impact on the follow-up, of course. So I think in terms of performance, hemodynamic performance of Navitor in small anatomy in such a context, I would say that this is maybe the ideal platform to choose related to this topic of patient prosthesis mismatch.
Great. So let's move to the next topic, which is permanent pacing. It's also a concern in these patients, particularly in young patients with a long life expectancy. You don't want them to get any complication if possible, and you don't want them to have a pacemaker for the rest of their life if it's not a necessity. Kentaro, you have a big experience, I think, and a lot of studies in the very early days, like really dissecting everything related to conduction abnormalities from prediction to outcome. Can you give us maybe your thoughts about that?
Okay, thank you very much. So maybe this is my slide. Actually, the permanent pacemaker still remains to be the complication to be avoided during the procedure. And everyone knows that the anatomical variation of the pacemaker implantation, and we really need to touch the membrane septum to avoid pacemaker implantation because the conduction atrioventricular bundle is there in the membrane septum. And there are a lot of the factors to be associated with the conduction disturbance, balloon predilatation, or to over expansion, and pre-existing RBBB, and post-dilatation. And prosthesis oversizing is also identified as a risk factor for the pacemaker, as well as the self-expanding device and the lower implantation depth. Therefore, the risk of the pacemaker is quite multifactorial, so therefore we need to avoid this complication. And some people use the cusp overlap or double cusp view to avoid the pacemaker implantation, to put the valve a little bit higher than the that we used to implant to the lower position. And this Midas approach is also quite important to avoid the pacemaker implantation. And in the screenings, we can identify the length of the membrane septum to tailor-make the position of the implantation depth. And from our Ocean TAVI registry, we published that there are huge inter- and intra-observer vulnerabilities in the measurement of the membrane septum. So some people use the method A and some people use method B. So it's quite important to talk about the length of membrane septum. And we identify the implantation depth itself predicts better for the risk of the pacemaker. So therefore, we need to take into account the length of the membrane septum as well as the implantation depth. And some people perform the rapid atrial pacing after TAVI to predict the requirement for the permanent pacemaker. That also seems to be a really nice method to predict the permanent pacemaker. And my good friend, Dr. Shinichi Shirai, is in charge of our Navitor database. And he found that we have the decrease in terms of the incidence of pacemaker requirement. Actually, in our early experience, we found that the incidence of pacemaker was slightly high, like 13%. But in our late experience, it decreased to the 8%. Even though it's not statistically different, we found that the Navitor is now much more stable to avoid the pacemaker implantation. And from our center, our former fellow Yusuke Kobari demonstrated that the distal opening technique to avoid non-uniform expansion. So because non-uniform expansion will be associated with the unexpected upward motion of the device, therefore, we usually open up the distal part of the Navitor valve inside of the left ventricle. It's okay with the only 45 degrees. And then so we put back the device and we implant the device at the 3 millimeter depth, and which provides you to avoid the non-uniform expansion. We really like this method. So I think that the conduction disturbance after TAVI is not rare, and the risk factor are RBBB and implantation depth and oversizing red and the self-expanding device. But I think that the meticulous screening and tailor-made device selection and implantation technique, for example, distal opening technique, and post-procedure management is quite important. Thank you.
Yeah, great. I think clearly the rate of permanent pacing in general, if you compare it to the early days of TAVI, they have gone down. They have gone down probably because of better devices, more precise implantation, but also the we have modified a little bit the way how we are implanting these devices. I found it very interesting the way you described how you implant the Navitor, but did you see any impact of this technique either positively or negatively on your pacemaker rates?
Actually, in our early experience, we experienced only one case that has the upward motion, like 5 millimeter or 6 millimeter after implantation, but it was caused by non-uniform expansion. So therefore, we really think that it's quite important to avoid non-uniform expansion. So we think about the open up the lower part of the Navitor valve inside of the ventricle, and after applying this technique, we never see the non-uniform expansion at all. So I think that is quite important technique to avoid non-uniform expansion and resulting in the unexpected upward motion. That means we can deploy exactly the 3 millimeter depth to avoid pacemaker implantation.
So it didn't impact your pacemaker implantation rate, whether neither positively or negatively, but it prevented this final upward motion of the device, correct?
Yes, exactly. I think that it impacted the incidence of pacemaker implantation because we can implant a little bit higher.
If we take this back to the patient we were discussing, I mean, this patient also has a more or less little bit low left main, coronary artery disease. It takes us a little bit also into the next topic, which is which I want to discuss with Antoinette a little bit. But before we go into the details of coronary artery disease and its impact and how we should manage revascularize before, after, and so on, when it comes to the decision-making process, you want to avoid pacemaker and you want to maintain coronary access. And obviously, these are like, competing interests. If you go a little bit deeper, you have a better access, but you have more pacemakers and vice versa. How should we decide?
I think it's quite a kind of a trade-off. If we implant too high, we can avoid pacemaker, but we're going to have the very difficult coronary access. On the other hand, if we implant too low, we have the pacemaker implantation, but the better coronary access. I think it's quite important to tailor-made or individualize the procedure for each patient and taking into account the length of the membranous septum as well as the patient age or pre-existing coronary artery disease.
But I mean, you showed us that at least in your analysis, the membranous septum wasn't that helpful. But on the other hand, some of us would like to maybe measure it in such a case in order to give us maybe a more, to be more comfortable with going deeper to maintain, for example, coronary access. So is this something that makes sense? If you have a longer septum, you can go a little bit deeper to maintain access in a young patient?
So maybe in our analysis, I think it's quite important to identify the very good method for the measurement of membranous septum. There's some people use method A and some people use method B. So it's important to establish the very good measurement method for the membranous septum. So of course, if we can implant much shallower, we're going to have the lower incidence of pacemaker implantation, but we also have the difficulty in terms of the coronary access in the future. So that means if the patient allows us to implant a little bit lower position, it's going to provide us the better coronary access in the future.
Okay. Thank you, Kentaro. Antoinette, let's move to the third problem of this patient, the presence of coronary artery disease. And I think this is also one of the things that if you compare again what we did in the past, what we're doing now, we were very strict with revascularizing all lesions before TAVI, and now we're probably more like comfortable of leaving them and maintaining access. So,
and I guess the difficulty is that we still don't, there's so much that we still don't know. And so if we look at even just the prevalence of coronary disease, so your patient, Hendrik, it's a 72-year-old, a low-risk patient. So it's the type of patient we're going to see who, we see this in about, maybe 10 to 20% of patients who are going to be referred for TAVI. The prevalence always depends on the definition and the risk of the patients that are being treated. So with higher risk populations, we see much higher prevalence of coronary artery disease. So the question is to revascularize, and it's just that, or not to revascularize. What do we do? And we really don't have any randomized data to guide us in these kind of situations. The trial that we do have is the activation trial. That's a trial that's going back a number of years now that really did try to tease this question out, that if we treat these patients, if we revascularize, does that translate into a mortality benefit? Because I guess the fear very much at the beginning was the instability that coronary disease could lend to the procedure in terms of hemodynamic problems. Could that be a problem and affect the outcome for these patients? So the activation trial was looking at non-inferiority of PCI versus no PCI, and it had some problems in terms of its power and all that, but really it didn't show us any benefit for performing PCI in these patients in terms of hard outcomes of death and hospitalizations. But if we do perform PCI in these patients, that it's at the expense of a higher bleeding risk. So I guess, when we see a patient like this and we see, very severe proximal vessel disease, what do we do? So we have consensus guidelines and recommendations that it's, a revascularization strategy in a patient like this is reasonable if it's proximal vessel disease. And I think we all would agree that this is a very reasonable thing to do. This doesn't quite fit into the category of the patient that you presented to us, and certainly in more intermediate disease, what is the benefit of physiology and physiological measurements, and what type of physiological measurement should we use? That's still something that's under evaluation. So, if we do decide to do it, and in a case that I just showed you there, in a proximal LAD left main case, when should we do it? So, do we do it up front before the TAVI procedure, get it out of the way? Can it be performed during the procedure? Or again, it can be performed afterwards. And this is from the Revasc TAVI registry from Marco Brabanti and their colleagues. And I think it brought up some very interesting points and interesting results. So they looked at its registry data, and they looked just at the 3 time points of performing revascularization. And I think very interestingly, there were about a quarter of the patients who had concomitant PCI and TAVI, which I think from my experience is unusual. The vast majority of the patients would have had pre-PCI TAVI, and a smaller proportion had post. But if you look at the outcomes, what is really interesting is that in PCI after TAVI, that seemed to translate into a benefit in terms of death MI, so heart failure rehospitalization. So it seemed to translate into a benefit in terms of hard outcomes. So all that to say that we really need more data, and it's a difficult decision. So your decision to revascularize was based on the IFR of the patient being positive, and that's something that's really undergoing very intensive investigation. So there are a lot of trials ongoing that are looking at different revascularization strategies. So these are all trials that are looking at complete revascularization, and they're all looking at revascularization pre-TAVI, which is interesting as well, given the recent outcomes from the Revasc TAVI registry that's been recently published.
Yeah, I mean, it's good that that our trials are upcoming. I find the TAVI PCI trial, as you mentioned, very interesting because it's looking at this question, like before versus after, and this is again something that has changed in our conceptual thinking. Also considering the fact that TAVI procedures are not that risky anymore like they used to be in the past. And it's probably, and I can understand these Italian results, because we all had bad experience with doing PCI in a patient with severe critical AS. And it's definitely much easier and much more comfortable for you and for the patient to do it afterwards if it's possible. But for that, you have to remain or to have coronary access after TAVI, correct?
Absolutely, and that's what it really comes down to, is that the one thing that we do know is the importance that we must preserve access afterwards. So, and coming back, depending on the type of anatomy for the patient, choosing the right valve for the right patient and basing that decision very much on the CT findings and the measurements that we derive from CT findings. So knowing the valves that are available to us, knowing the impact that they're potentially going to have in terms of coronary access, and thinking on down the road, because this is a 72-year-old lady who has a life expectancy of more than 15 years and has a significant likelihood of needing a second valve. So the importance of not only acutely preserving the access, but also thinking about sequencing from the future, and also choosing a valve that will allow you to align commissurally, or as much as possible will give you the possibility to have good commissural alignment, because that is also going to be equally important in terms of getting re-access to those coronaries. How real is the need for re-access? Well, we have some registry data, and I think from the UK TAVI registry, it's about 0.7% of patients that will come back for a coronary intervention. But again, it's registry data and very variable depending on the series that we look at. So it's not very frequent, but if we're faced against difficult access, it's a very real problem.
Yeah, and I think yesterday in one of the sessions there was an excellent comment actually from I think from Kim, from Dr. Kim, that we shouldn't be happy that coronary access is possible in 95% of the cases, because actually this is not acceptable. It has to be possible in 100% of cases after TAVI. You cannot exclude 5% and say, okay, if these come up again with an ACS, then I don't have access. It's not acceptable, correct?
It's your worst nightmare.
Yeah. Great. So THV design, does it play a role in the ability to obtain coronary access?
I mean, certainly with some platforms, it's possible, and others it's very much more variable. But we can see that very much that industry is dealing with that, and all valve manufacturers are now really making efforts to make it possible, because of that. Because if we end up in a situation where we have misalignment, it closes off our access, and it can be extremely difficult.
Yeah. Great. So we have a lot of like a long wish list for the ideal device for the patient you presented. So ideally, we want this patient to get a device that doesn't cause PPM. We don't want this lady to get a permanent pacemaker. And we want to maintain coronary access, obviously, because she has coronary artery disease and has been treated already. And there are a lot of other wishes, of course, like it has to be, she's young and she has a longer life expectancy. We want a perfect durability, and we want the option for re-intervention if possible. So it's a tough call. So want to show us what you decided and how you treated?
Yeah, let's see if I fulfill all your wishes on your wish list. Try to be your Santa Claus, even though it's only November. So this is the result or the review of what we actually did. And this is the device we eventually selected. We chose the Navitor because of a couple of its features that are highlighted on this slide. So of course it has a large cell design, so coronary access is easier and more obtainable, more easily obtainable with the large access through these cells. Then we have the intra-annular valve design, which means that potential neoskirt is less of an issue, and there's also easier access to the coronary ostia, especially on the left side with the low uptake of the LCA. It has a Navitor cuff design, which prevents leaks, which is something that we didn't discuss, but it's of course very important for younger patients to have an optimal hemodynamic, not only in terms of gradient, but also in terms of the prevention of any parallel aortic regurgitation. And it has a non-tapered design, which I guess also contributes to the hemodynamics that are usually comparable to other self-expandable valves, even with supraannular designs. So those are the images from the procedure. We started just in a normal fashion with an angiogram, and then we attempted commissural alignment as suggested by the group from Lars Sondergaard some years ago. So that means that we projected, or that we chose a cusp overlap projection and put a stent frame This post here on the left side, basically of the patient, the right side of the screen, facing the commissure between the right and the left coronary cusp, and therefore aligning the valve according to coronary anatomy. And this is the release. As you can see, it's a rather stable release because of the intra-annular design. There is no low flow phase, almost nothing compared to other supra-annular designs, which means that you only have to do fast pacing. Basically, you don't actually have to do that. I use it because it makes it easier to have a stable position because you don't have any arrhythmias caused by the wire. But in terms of hemodynamics, you don't have any low flow phase, so the device is always rather stable. So then we, of course, did our angio checks in RAO cusp overlap view and also in the LAO view to make sure that we have a good implantation depth. And finally, we released the device as seen here, again, rather controlled and a safe thing to do. Usually I do about 100 beats per minute pacing in this situation, again, just to have a stable annulus without any escape beats. And this is the angio after release. And you see we attempted for a fairly high implant to avoid any risk in terms of pacemaker implantation because we were comfortable that given the design features and the commissure alignment, we would be able to get access to the coronaries quite easily, even in the LCA. And this is the final echo before discharge. You see there's no relevant PVL, and the final gradient was 9 millimeters of mercury mean, which means single digits, so fairly well given the risk for patient persistence mismatch in this patient. And this is the discharge EKG, so no changes at all, small QRS, no prolonged PR time, so fairly great result for the patient, we believe, and hopefully for her lifetime management.
Maybe before moving to further discussion, we have some questions coming from the floor, mainly related to how to manage coronary artery disease in TAVI patients. So still, we have no clear guideline, no clear consensus, and I think there is a lot of discussing in this regard, and this is reflected by the question. For example, one interesting question is, we have several evidence that in chronic coronary artery disease, there is no really benefit in doing PCI. Why should it be different in a patient with asymptomatic, angiographically relevant coronary artery disease undergoing TAVI?
Let's take this question to Antoinette.
Of course, there is no evidence that it translates in chronic coronary disease. And I guess what we do have evidence is that if it's physiologically guided, that there is a benefit. And that's why a lot of these ongoing studies are using FFR, IFR, just to try and tease that out further. Because I think if it's just going to be non-physiologically directed complete revascularization, why would we why would we expect it to be any better? But I think what's interesting about what's coming down the line is it's going to give us physiological and it's going to give us evidence as well in terms of FFR, IFR.
And maybe another point, you already mentioned obviously the location, so the proximity of the lesion, which is obviously
and
important.
it's in the eye of the beholder. It's angiographically, it's proximal major epicardial vessel, and as a cutoff of more than 70%, but that's a visual estimation. So again, it's in the eye of the beholder. It's in the eye of the cardiologist who's doing the intervention. So it's
how much the
quite variable.
Complexity of the lesion calcification rather than is influencing your practice. So if the lesion is, let's say, supposed to be really complex to treat, would you rather do it after? If it is an easy and quick lesion to treat, you just do it before, like Henrik did in this case. What's your recipe, if you have one, obviously?
I mean, it very much depends on the patient. And, sometimes things that seem very easy can end up becoming very complicated. But certainly you need to take the patient that's in front of you, and the decision needs to be relevant to the patient. So, I mean, if the primary symptoms are heart failure symptoms and not angina, and it's not left main or proximal LAD, I would be very much in favour of managing that coronary disease conservatively, treating the big stenosis, which is the aortic valve, and then seeing your patient back. And I guess the encouraging data that we've seen is from the REACCESS, from the Revasc TAVI trial and REACCESS 2 now as well, is that, we can get back there then if we need to, but don't complicate things too much for your patients and look at the patient that's in front of you.
Yeah, thank you. I think we have one more really important aspect to discuss. Obviously, this is a young patient. We have been trying to address all the issues that may impact on the follow-up, but young patient means long life expectancy. So we have to acknowledge that there is a chance, quite a high chance, that this patient will come back with a degenerated prosthesis that may require a further intervention. What to do in this case? Obviously, one option, maybe not for this patient who rejected the surgery already at the index procedure, but would be to consider surgery, so TAVI explant. And obviously, TAVI explant is associated with some technical challenges that are not present during the first procedure. So it's not like to just perform a simple AVR. And these are mostly related to the fact that the patient is maybe older when he's coming back. So overall, the impact of our surgery in the patient at the second stage is higher. And then there are some other technical aspects that we have to consider. And maybe if you can show the slide quickly, that explain the difference in impact. There are no randomized trials showing actually comparing repeat TAVI, so TAVI in TAVI versus TAVI explant, so surgery in patient with a degenerated TAVI prosthesis. But observational trial like the EXPAND TAVI registry showed that the impact of surgery is heavier. So there is more mortality, more morbidity, is something that is more challenging to do it, and probably we should try to avoid unless we have alternatives. And one of the reasons is that actually the stent of the valve could make some adhesion to the aortic wall, so it may not be just a simple AVR. Now we are learning how to explant TAVI devices even when we perform surgery in a slightly less invasive way, but we have to acknowledge that at least 30% of the patient may require a more extensive surgery like root replacement, put a conduit or ascending aortic replacement. It could be challenging to clamp, but we may have some calcification. So it's a more heavy surgery. And this obviously reflects in a patient that is older compared to the first operation in a more important morbidity burden and mortality as well. Last but not least, at least now, there is few experience in this kind of surgery, which is highly specialized and highly technically challenging. If you look at the case volume per center in US, where the numbers are increasing, obviously, because the more we perform TAVI in younger patients, the more we will see degenerated TAVI. But still, the number of cases per surgeon compared to the number of centers is extremely low. So there is a median of 1 case per surgeon per year among more than 300 centers who included patients in the TVT registry. So it's a challenging scenario. We don't have that much experience, and probably we should consider to perform a second TAVI, which is as well associated with some challenges. And maybe we can discuss which are the challenges in a case like this, in case maybe 10 years later the patient will come again and would need a second valve.
Yeah, of course. I mean, I think this is probably the first approach everybody would go for, to do a TAV and TAVI procedure in a patient that already obviously underwent TAVI for the index procedure, so had some reasons to avoid surgery. So of course we developed techniques and approaches to tackle these cases, and as recently published together with at TCT, I guess, we have this large Lancet registry, or published in the Lancet, that showed that actually it's probably safe to do that in, of course, selected patients. It was not randomized, but it fits our experience that we usually can do it. But we have to, I think, select these patients and prepare the procedures meticulously, because, as you can see here in these, basically CT studies after TAVI procedures, there is a certain risk for sinus sequestration, especially if you implant a self-expandable valve. As you can see here, almost 50%, half of these patients in the CT study after standard TAVI had a risk for sinus sequestration, meaning a risk for coronary obstruction due to the leaflets reaching the sinotubular junction and then basically isolating the sinuses, reducing the flow to the coronaries. And this is, of course, very much dependent on the valve design, because the neoskirt is dependent on the leaflet design and the length of the leaflets. And of course, some reports have been published analyzing the different designs by just, putting the leaflets as high as possible and then measuring the neoskirt height. And there are, of course, differences, as you can see here. The supra-annular designs of Accurate Neo and Evolut Pro, of course, result in rather long neoskirt heights compared to Portico and Navitor, which are, of course, intra-annular designs. But there's also the other question. Okay, if you want to avoid neoskirt height, then you should probably just put in a balloon expandable valve as low as possible. But recent bench side studies have, of course, revealed the new issue that probably a few of us never thought about a couple of years ago, is the issue of leaflet overhang. Is there an issue when the leaflets are hanging over the new second device? Does it affect hemodynamics? And of course, it very much depends on the position of the second valve, of the balloon expandable valve in the larger stent frame, in terms of the effects on this leaflet overhang. If you have a low implant or a higher implant, there are a couple of simulations now that give you a rough idea how much of a percentage of leaflet overhang you have and how much that might influence your hemodynamics. And in terms of terminology, you have to look at these images here. So a low implant means that we are at node 4 in a standard Evolut, for instance. Intermediate implantation would be node 5, and a high implant would be node 6. And this terminology is also used in this study here that was recently published, and that basically did a bench-side test of these different implantation heights for TAVI and TAVR simulations. And you can see here, if you have a low implant at node 4, of course, the neoskirt height is lower as expected compared to node 6, a very high implant. But this also, of course, inversely results in a lot of leaflet overhang of about 90% in a very low implant position compared to a high implant. The question is, does it affect hemodynamics? And there is some slight data or some indication that you might have a larger or a higher gradient if you go low and have more leaflet overhang compared to a high implant. But on the other hand, this might also affect regurgitation fraction, but overall this is rather low. So we are still learning about this, I think, and in the end, as always, probably in life, the gold middle is probably the best way to go right now, to go for an intermediate height implantation in these situations, because of course you want to balance hemodynamics and coronary access in these situations. And for our patient, the great people at FIOPS did a simulation of the case I just presented, and as you can see, if you measure the implantation height, I think we were about 2 millimeters, and put or simulate an S3 into this device, into the Navitor that we implanted at about at an intermediate height. We have some overlap with the RCA, but I guess it's going to be safe. So I would call it Vivid 1 in this in this classification of risk of coronary obstruction. The low uptake, of course, of the left coronary would mean that the neoskirt height would be above of the ostium of the left coronary, but the distance to the stent frame in the simulation is 4 millimeters, so I'd call it Vivid 2A, so I guess it would be safe to do a valve-in-valve procedure in our patient. And the leaflet length and overhang would be in the average side, probably due to the intra-annular design. And to finish this discussion, I'll just show you one case we did a couple of years ago on a degenerated portico, which I think illustrates that in many cases, and we did a few, this is usually a rather safe procedure because of the intra-annular design. We always had a good confidence that the neoskirt height would not be a problem, and this is the implantation. Again, this was before we were worried about leaflet overhangs, so we did a rather low implant and had a very good result. And this also means that to be honest, maybe we can discuss this leaflet overhang. Is it something that we only discussed because we see it in bench-side tests, or is it really relevant because the patients that we treated like so usually had good outcomes with no regurgitation, and here we had a mean gradient of 8 millimeters of mercury. So even if there was leaflet overhang in the acute effect, it was rather not an issue.
Yeah, great. I mean, a lot of things here that we can maybe discuss a little bit more in more depth in the few remaining minutes. So you mentioned leaflet overhang. Philippe, from your hemodynamic perspective, obviously it will be different if according to the failure mechanism of the device. So if it's a pure regurgitation, as you showed, probably we can accept leaflet overhang because it will not impact the outcome. But in calcified degenerated valve, I'm struggling to understand how much leaflet overhang can we accept in order to have good hemodynamics with the second device.
Yeah, I think it all depends where the calcification is located, and there are different mode of failure. And I agree with you, if it's AR, the leaflets are relatively thin, and it may still have an impact for the coronary flow, but not for the hemodynamics of the valve. But if you have calcification, especially of the free margin, we often see these cases where the free margin is really calcified. This is maybe where this may have more impact. So it very much depends, not only on the mode of failure, stenosis versus regurgitation, but also where the calcification is distributed. If you have bulky calcification, especially at the free margin versus at the base, might have more impact potentially.
Is it something that can only be solved with looking at this in the bench?
Yeah, I think, because, clinically we have small numbers, and all patients are different, have different situations. So to get sufficient number of patients in each subgroup with the different, severity of overhang and the different type, it's difficult to do analysis. So I think this is something that we have to address primarily on the bench. And then eventually do some clinical validation within the patient we have. Yeah, absolutely.
And Kentaro, maybe one final question. Is this simulation that we've seen with this software or with others, is it something that we're going to do more frequently in the future, maybe even before implanting the index valve, just to understand what are the combinations that are possible? Do you think this is coming?
Actually, the indication of TAVI is shifting towards much younger and low-risk patient. It's quite important to tailor-made our treatment strategy. And if we can use this kind of very good software, it's quite easier for us to anticipate what's happening in the next procedure. So we really need to tailor-made and anticipate the second procedure at the time of the first procedure. I think it is quite important technique in the software.
Okay, thank you. Great. So, to sum up what we've seen in this session, the case that looks maybe anatomically straightforward, if this is a patient that is young and has a long life expectancy, you can see here that there are a lot of considerations that you have to pay attention to before we engage with implanting a transcatheter valve. So it's not only the acute success, of course the acute success is essential, but it's also what will happen afterwards with this patient. Can we keep coronary access? Can we achieve good hemodynamics, obviously with as little ppm as possible to ensure valve durability? And if the patient is going to outlive his or her valve, do we have options to retreat these patients? Particularly that if we start intervention, you probably don't want to end with a surgical procedure. So I think the case that has been presented summarized all of this in a very beautiful way. So thank you very much, Maurizio.
Thank you.
Thank you very much to all the experts. And thank you for attending the session. Thank you for sponsoring it by Abbott. And I hope you enjoy the few hours left during London Valves.